Welcome to the latest in our series of expert videos. Today we welcome Penny Dash to talk all things ICS. Penny comes with a wealth of experience and is currently chair of North West London ICS, has held positions as a senior partner in McKinsey at the Boston Consulting Group and has also chaired the King's Fund. Penny, welcome.
Thank you.
Can we start off with some of the basics, please? Tell us about ICSs and their current state of evolution, because we're very aware they're probably at different stages of maturity.
An ICS is an integrated care system which seeks to bring together all of the players involved in health and care for a defined population of people. So North West London basically goes from central London out to Heathrow, around the M25 up to the north, and includes around 2.5 million people. We have 8 local authorities who are part of the Integrated Care Partnership, or the ICP. And then on the NHS side, we have 8 trusts. Half of them are community and mental health, half of them are acute trusts. We have 400 GP practices, we have a whole host of voluntary sector services and so on. And the ICS brings everyone together, and the ICB, the Integrated Care Board, is responsible for overseeing all of that, for essentially ensuring good use of funds. So our budget for the NHS side, or the healthcare side, is just over £5 billion. And then we work closely with the local authorities who are responsible for public health and for social care.
That setup, that architecture, is the same across other regions, presumably around England?
The architecture in terms of a defined population, including everything in it, is the same. The way in which the ICPs, the Integrated Care Partnerships, have been set up, the way in which the ICB is organising itself, the way in which the providers are being organised, that is all a bit different around the country. That's the bit that's starting to emerge, is these quite different ways of organising within the ICSs, as well as some of the different priorities.
So as systems, ICBs, ICPs start to mature,
Yeah.
What are you seeing as the biggest challenges that they're facing?
There are lots of challenges. I'll try and set those out in a reasonably structured way. One big challenge is, as you can read in the papers, the health status of the population is not improving and actually possibly getting worse. And so that is the first time we've seen that really in 80 years, well, 100 years, if not 150 years. So we've had this really quite dramatic increase in life expectancy. We've had a big increase as well in terms of numbers of years lived healthily. Of course, those two aren't the same. We've had that over that very long period, and now it's completely flattening out. And the rate of improvement in the last 20 years has been very positive, big improvements in cardiovascular health and in cancer in particular, both related to reductions in smoking, in new treatments like statins, as well as things like stents and so on, and all the new cancer drugs. All of that you can see a very big improvement and no longer. So that is really quite worrying. It's not just a bottoming out, it's actually a going into reverse. That is a big challenge that we're facing. So while we recognise both overall health status and inequalities as one of our biggest priorities, the number of people involved in that and relative accountability is very muddled. So that is a big challenge. The second big challenge is what I might call local care. So primary care, community care, social care, as well as local mental health care. We can all talk a fine talk about integrating those services, having better quality in those services, making it easier to access those services. But again, as we all know at the moment, they are not working as well as they could. The sort of final big one really is about looking at all of our hospital services, but also other services, and looking at how well they are organised and run. We certainly know that we could be getting through the waiting lists more quickly if we were able to run our operating theatres more effectively, if we were able to change some of the models of outpatient care that people have been talking about for many, many years. But doing all of that is a big change management job, and that requires a lot of management resource, a lot of clinical resource and so on, and takes time to do.
And what about then some of the successes that you're starting to see, and particularly perhaps some examples from North West London of things that may not have happened if we'd have stayed in the provider model and we hadn't have moved to systems?
We are now, at least between the NHS and local authorities, all sitting around the same table to talk about how do we support improvements in people's health and address inequalities. So that has to be a good thing. And as I said before, I'm not sure we have the answers, but at least we're starting to have the conversations. We do have the capacity now, working across all of those services and across a big population, to look at the data, to be thinking about prioritisation, to think through where should we direct resources, where's the greatest need, where can we have the biggest impact, and where can we share best practice. We have organised our services for primary community mental health and social care very much at the local level. We've now put in place a clear management team in each of the boroughs, so that's covering a population of around 250,000, and within that we then have typically 5 or 6 integrated neighbourhood teams, and we are clarifying the governance structures, the lines of responsibility, who's doing what, how do we invest money in improving those services, how do we deploy digital tools, so like using better telephony systems so you can share some of the phone call systems when telephones get overwhelmed and so on. And so we've making slow, but we are making progress on all of that. The other one I would point to is across our acute hospitals, which in North West London have been in very high levels of competition with each other, not particularly good at cooperating. They are now working very effectively together. So those would be, I'd say, some of the things that actually are making a big difference now. And then in terms of the future planning, I think at that size, we're much better able to plan for new approaches like really using digital tools much more effectively, looking at data and data systems and supporting research, innovation, getting that into practice.
How can suppliers like Sodexo and non-FM suppliers, how can we help in this journey that ICSs are going on?
ICSs have 4 main objectives: improve population health, ensure high quality care, productive services, also support wider economic and social growth. Across all of those, essentially we need to work through all of the organisations involved in delivering health and care and support to people. The landscape at the moment in the UK is that all of those things are provided by loads of organisations. It's quite interesting, sort of catch-all of the NHS. But the reality is there are lots and lots and lots of organisations involved, and even in a hospital it could be anything from the people who build the buildings through the people who maintain the buildings through to people who provide the drugs and the equipment, and the list goes on and on and on and on. This is a very, very broad group of people involved in helping us to meet those objectives. Big thing I think is that we all need to be on the same page. I always find it slightly strange when you hear one particular sort of supplier or one particular bit of the system, and that that could be anything from a group of nurses through to a company providing bits of kit that might talk about something which isn't really part of those objectives, and you go, well, hang on, how does that fit in then? So I think for me that's the biggest thing. We all need to be part of it, and we all need to work together to deliver on those objectives. And so that means, how is any other supplier contributing to improving health? How's any other supplier contributing to ensuring high quality care? How's any other supplier contributing to ensuring really efficient, productive services? Because if we can have really efficient, productive services, then that frees up more resource to help more people. So actually, efficiency and productivity is the biggest lever we've got to help more people, to improve the health of the population, to reduce inequalities in health. An awful lot flows from that. So anything that you can do on any of those to help us has to be a good thing. But there is this 4th objective, which is interesting, around wider economic and social impact, because as well as being a supplier, you're an employer, and you're an employer of people who may well live within North West London. Certainly they'll live somewhere. And so how you think about supporting your employees, how you think about the role of employment and improving people's health, how you think about what wellness services you provide to your employees, that actually really matters as well. And that's something that perhaps hasn't been quite as much attention to as there could be over the last few years. And that's why that 4th objective that we've been given as ICS is quite an interesting one. And so how do we in North West London, but of course a lot of this goes much wider than that, how do we work with all of the employers in the patch? How do we work with all the voluntary sector groups? How do we work with all the communities to really think through, we're all in this together, we're all here to think about our health. We know that having a healthier population leads to wider economic and social growth. So how do we all work together to do that? So that's a key bit of that conversation really. As I say, it's your employees that I care about as well as the business that you're offering.
So let me finish up then with your vision as to what ICSs will look like in 5 years' time. How different will they be from today, and how will that feel from a provider's point of view?
I think where we're likely to end up is actually with these variations on a theme. Even within London, you can see quite a bit of that. We have organised ourselves across 8 boroughs, each with integrated primary community mental health and so on, working with all of them, our community mental health trusts, where we are increasingly looking for them to work effectively together to support those 8 boroughs. We then got our 4 acute trusts, which again we brought into essentially a group model with a single chair. So that's our delivery mechanism. And then in terms of us as the ICB, we're essentially a strategic commissioner. So we are saying, okay, we've got £5 billion to improve the health of the population. what are the sorts of interventions that we should be looking for, what's the most efficient way of delivering those interventions, and so on. And then we're working with that provider structure to deliver it. So that's how we see the world. And there are other ICSs doing something similar. In some other places, the ICS is primarily and almost exclusively focused on population health. So I'm working with local authorities in terms of how do we address the wide determinants of health. And all of the NHS side, they're essentially delegated to a provider, which they're sometimes calling a provider collaborative, or they're sometimes calling a place. But the place could be quite a big geography, like a population of 1 million. And so there's quite a few ICSs gone down that route, where the ICS is, say, working very much with local authorities, and then they'll have 2 places, each one with a population of 500,000 or 1 million population, with a single vertically integrated provider that covers acute, community, mental health and primary care. The other bit, which is much discussed, is do we continue with lots of different providers, or do we have consolidation? And it could be in either of those 2 ways I described, and we might move to fewer, bigger trusts. And then there's a continual question mark about foundation trusts and how do they work within these new structures. Those are the things where we'll see differences. The other thing worth mentioning is what happens to primary care. I think we'll see probably either larger partnerships, or we'll see more employment models with primary care employed through trusts, again, as is happening around the country. So I think we'll see those models evolving as well.
Fascinating.
Who knows?
Fascinating. Penny, thank you so much for your time,
Pleasure.
sharing your view on ICSs, your progress in North West London. We look forward to seeing what opportunities obviously arise, and I think we do see an opportunity in terms of scaling up what we do within a region.
So great
to be part of it. Thank you so much for your time.
Thank you.